Welcome to this special segment, What You Need to Know About Breast Cancer, presented by AZCCC, the Arizona Center for Cancer Care. I'm your host, Mark Lewis, and we'll be covering many topics in our three segments as they relate to breast cancer. I'll be joined by two physicians representing AZCCC, and I'd like to introduce you to them right now. Dr. Noemi Sigalove. Dr. Sigalove specializes in treating both benign and malignant diseases of the breast. Experienced in minimally invasive techniques, she focuses on care with compassion and emphasizes the team approach to fighting cancer. She strives to achieve the most optimal cancer treatment with the least amount of disfigurement to the breast. Partnering with her husband, a reconstructive surgeon, Dr. Sigalove helped advance novel surgical techniques that minimize pain, maximize recovery, and enhance the appearance of the reconstructed breast. With multiple publications, she actively lectures and continues to teach the technique of nipple-sparing mastectomy with pre-pectoral reconstruction. Dr. Sigalove's practice philosophy is based on the premise that in medicine, you always have the ability to do the right thing, and together we can accomplish what no one can achieve alone. Dr. Stephanie Lindauer. Dr. Stephanie Lindauer specializes in medical oncology, hematology, and internal medicine. Her clinical interests include breast cancer, gastrointestinal cancer, hematologic malignancies, and cancer survivorship. Dr. Lindauer joined Arizona Center for Cancer Care in 2018. Dr. Lindauer has several abstracts and poster presentations at local and national meetings, including ASCO Survivorship Symposium, ASCO Quality Care Symposium, and ASH Hematologic Malignancies. Dr. Lindauer was drawn to the field of oncology from a young age, having seen the effects of cancer in loved ones. She feels honored to be able to fulfill such an important role now and strives for compassion and empathy with all of her patients. Dr. Lindauer is a member of the American Society of Clinical Oncology and American Society of Hematology. She enjoys spending time with her husband and her two dogs. Doctors, thank you so much for joining us. This is a great opportunity for us to present the viewing audience with an overview of breast cancer from your perspective as clinicians, and we appreciate you both being here today. Let's start at the beginning from a clinical perspective. What is breast cancer, and then what percentage of women in their lifetime will be touched by this disease?
So breast cancer in its most basic form is a tumor that starts in the breast tissue. So cells within either the milk ducts or milk glands grow abnormally, and eventually this becomes either a mass we can feel or a mass we can see on imaging. And so that's breast cancer in its most basic form. As far as incidence, so unfortunately, breast cancer is the most common type of breast cancer that affects women in the United States, and about 1 in 8 women in their lifetime will develop breast cancer.
Wow, that's a pretty high percentage. So I know it's touched a lot of our families, and that's why I think there's such a heightened awareness about it. But I think we want to overcome some myths about it too, and we want to give good clinical information so we can kind of knock down the fear factor and approach it from a clinical factor. Dr. Sigelov, what are some of the warning signs for women when maybe doing their self-exam, and how do they differentiate between something that might be more benign, or that's why they need to come to you to have it evaluated?
So very interestingly, it used to be that most breast cancers were actually felt by women themselves. And oftentimes when they came to the doctor, that cancer was large and coming through sometimes the skin. But that has changed a lot recently because we have started to do mammograms and ultrasounds and screening. And so the majority of breast cancers nowadays are actually found on imaging and not on self-exam. So we kind of stopped doing self-exams, and now we call it self-awareness, in that just taking a shower, when a woman takes a shower, uses soap and water and washes their body, if they feel something different in their breast than what's usual, that's when they have to bring it to the attention of their doctor.
And from a preventative standpoint, you talked about clinically what you can do with the mammograms and the MRIs and the ability to ascertain that. So is that a recommended procedure now for women past a certain age, or is it all predicated on family history and history of the individual?
One of the most important things that we can do is to figure out what a person's risk factor is for breast cancer. And that's a very personalized number. And we have various ways of assessing that. We look at somebody's age, we look at somebody's family history, we look at their genetic possibility of having a genetic mutation. We can put all those things into a calculator and see what somebody's risk is. And then we base that screening and exams and what we're going to do based on that particular number. And Stephanie can talk to you a little bit more about that too.
So it can be really confusing for women as to what age do I start screening, because if you look at the different medical societies, there's a lot of different varying recommendations and they're not always consistent. And so as Noemi was speaking about individualized plan for screening, with all of the information that we have now, we're really able to hone in on that specific woman's risk. So looking, for example, at family history, looking at genetics, certain genetic mutations, looking at medical problems in their past. For example, a woman with a history of lymphoma who may have gotten radiation to the chest wall. You know, all of these things play a factor in that woman's risk in her lifetime of developing breast cancer. And so we may alter our recommendations as far as age or modalities of imaging based on those risks. And so we're able to provide that service here by seeing these high-risk women and being able to individualize that plan for them.
Well, this was a later question I was going to have, but it's appropriate to segue off of that point. How much, with genomics now and the ability to ascertain family histories, that you're getting more information, have you been able to quantify a heredity marker, as it were, for individuals?
So about 5 to 10% of all breast cancers are truly hereditary, meaning linked to a specific genetic syndrome, such as the BRCA1 and 2 that a lot of people are familiar with. Additionally, about maybe 15% or so of women will have breast cancer and a positive family history, but maybe not that known genetic predisposition such as the BRCA1 and 2. That being said, there are a lot more genes now that we can profile for in addition to BRCA1 and 2 that may put that woman at increased risk for developing breast cancer. And additionally, probably a lot more we haven't been able to isolate yet. But the actual true incidence of hereditary breast cancer is about that 5 to 10%, although genetics are very important, and most likely it's a combination of genetics as well as other factors that play a role in a woman's risk for development of breast cancer.
Would you like to add anything to that?
So when I first started practicing about 20 years ago, we had two genes. They were the BRCA1 and BRCA2, and that's all we knew about. And it's important that those people who got tested for the BRCA1 and BRCA2 gene many, many years ago, but have a very strong family history for breast cancer, that they consider perhaps retesting with a wider panel, which is now called a full panel. But we're never really going to get a full panel until we have analyzed every single mutation and every single gene. Mm-hmm. So this is an ongoing process and changing. Mm-hmm. And this is also why it's important to have people like Stephanie, who's an oncologist, when you have breast cancer for life, because that oncologist is going to keep an eye on you and always be able to change things and update things in your profile and retest you if needed, so that you are in touch with being current for your breast cancer care.
And I wanted to mention, just from a personal standpoint, my wife many years ago was diagnosed with fibroids, but we didn't know until she had the actual surgical procedure to determine, the composition of it. So in in the breast cancer arena, are there false positives sometimes, or are you able to ascertain, like in her case, once they did the biopsy and saw that it was just a fibroid, it was not cancerous? They don't even follow her, so we felt a lot better. How does that work?
Well, a long time ago, whenever somebody had something that was palpable, next day they were in the operating room and we took it out and left a big scar, and just to determine what that was palpable. Nowadays, we try not to do that because there are much smaller procedures that we can do to find out what a palpable mass is. So we can do a biopsy just with a small needle to take some pieces out of that tissue and say, hey, this is just a fibroadenoma. We don't have to worry about this. It's not going to change into anything, just like your wife's little mass was. Sometimes you can have tissue that comes back as indeterminate, meaning we're not really sure, in which case we will plan another surgery. And then in a small percentage, maybe 10% of the 100% that we do biopsies does come back as a malignancy or cancer. So when that happens, the advantage of not having gone in and done that big surgery to begin with is that now we can plan, and we can take a person to the operating room only one time and do the right surgery instead of doing a whole bunch of different things and then having scars all over a woman's breast.
So it's much more comprehensive now, and you have options.
Correct, and
right.
much more precise in
and that's good
determining
news
a diagnosis.
for the ladies out there in the audience, because I'm sure, again, when you think A, you might have it, and B, it's identified, which we'll talk about in a later segment, you know, all the fear factors come in, the C word, you know, you hear about this, and if the way you can mitigate and knock down that fear is with a more comprehensive evaluation process, right? To be able to hone in on the appropriate technique to utilize going forward.
Absolutely. The right thing is not necessarily the fast thing.
Well, in this segment, we've, I think, given you a comprehensive overview. Doctors, thank you very much. We'll be back with segment 2 in a moment. But if you'd like more information on AZCCC, you can go to ArizonaCCC.com.